Hello, colleagues, ladies and gentlemen. My name is Andrew Coates. I'm president of the Heart Failure Association, ESC, and I give pleasure in giving a presentation on novel device therapy in heart failure and for valve disease. Here are my declarations. First of all, we have very many treatments for the management of heart failure with reduced ejection fraction. The vast majority are pharmacological treatments, but there have been a few device treatments, as we see down here, largely for the management of all patients, or the majority, with heart failure and reduced ejection fraction. In the most recent European guidelines, we have sections that include devices. They're a relative minority, not in the so-called 4 foundational classes, but we have CRTs, pacing devices, and ICDs, as well as selective recommendations, class 2A recommendations for MitraClip, mitral valve repair for functional MR, as well as some long-term mechanical circulatory support with ventricular assist devices. But we must remember we have multiple aims when we're treating heart failure. One is, yes, we want to make patients live longer, delay mortality, as well as preventing heart failure admissions, but we also want to improve patients' health status, improve quality of life, functional capacity, and improve symptoms. And that's where many novel devices are showing they're possible for benefits. Now, how do we assess that? Well, it's easy for mortality. I say easy. It requires large trials, but everyone knows exactly what you measure. It's mortality and increasing your heart failure hospitalization. But when it comes to quality of life endpoints, we need to have a validated questionnaire, and the 2 most common are the Kansas City Cardiomyopathy Questionnaire and the Minnesota Living with Heart Failure Questionnaire. But we also have objective tests of functional capacity, such as the 6-minute corridor walk test, the cardiopulmonary exercise test-based peak VO2, and lesser used activity monitors that look at regular physical activity. And improvements in those can be worthwhile endpoints. But importantly, when we're looking at device treatments, we also have to look at the common comorbidities of heart failure, which we see in the vast majority of patients. And they can cover everything from coronary artery disease through to diabetes, valve disease, sleep disorders, iron deficiency, and many, many others. And in some of these, devices may have a particular role to play. Firstly, I'll concentrate on valve disease complicating heart failure. We know that mitral and aortic valve disease increase in prevalence steeply with age, as does heart failure. So it's not surprising there's a lot of valve disease in a heart failure population. Here, this I borrowed from a video at Schioncell. It looks as the epidemiology and baseline characteristics from the European long-term heart failure registry at baseline. And we see clinically it's documented that valve disease occurs in about 12% of patients. But on echo, we see we get much higher prevalences, with nearly 50% showing mitral regurgitation and over a third showing tricuspid regurgitation. So clearly the clinical history underrepresents the importance of valve disease as being a comorbidity associated with heart failure. First of all, what are the recommendations for device therapy of valve disease? Well, first of all, we have aortic stenosis, where, of course, surgery has been a long-term treatment for severe aortic stenosis. It can be either congenital or degenerative associated with age. We know how to assess the severity based on echo as well as symptom scores. And now we can see the recommendations for the management of severe aortic stenosis leads down to the bottom to recommendation of either very careful observation, surgical aortic valve replacement, or the possibility of transcutaneous aortic valve implantation, which is increasingly seen as an option for patients who are too sick or too high risk for conventional surgical treatment. And of course, we have certain things that favor transcutaneous AVR versus surgical AVR. And predominantly, it's that the lower risk patient is a surgical case. But increasingly, we're seeing comparative studies suggesting that the transcutaneous procedure may actually increase in prevalence as a treatment option for severe aortic stenosis complicating heart failure. Then we turn to mitral valve, and mitral regurgitation has long been associated with heart failure and reduced ejection fraction. That can be of multiple forms. We can have primary valve disease, which can actually be a cause of heart failure and may require specific intervention, but also we can get mitral regurgitation secondary to heart failure, either due to enlarged atrium, enlarging the mitral valve ring, or either a non-ischemic or an ischemic cardiomyopathy process, causing functional regurgitation, which may be symmetrical or asymmetrical, depending on whether there is a localized cause for mitral valve dysfunction. Two major trials for one percutaneous treatment for mitral regurgitation functional are the MITRA-FR trial and the COAPT trial that had the same device in similar patients. One was completely neutral, the other had a very prominent result with a 37% protection from the composite endpoint of death or heart failure hospitalization. The difference is not entirely clear, but it does appear they recruited slightly different patients in that the COAPT trial had more severe MR but less severe LV dilatation, whereas the MITRA-FR had more severe left ventricular impairment but slightly less severe MR. So therefore, the careful selection of patients with disproportionate mitral regurgitation is recommended when we're applying the MitraClip device for the management of symptomatic functional MR in the presence of heart failure with reduced ejection fraction. There are many other devices being in development for mitral regurgitation reduction in heart failure. Probably beyond the MitraClip, the most advanced is the Carillion system, which is relatively non-invasive because it only goes into the coronary sinus. It doesn't directly affect the mitral valve apparatus and actually reduces the diameter of the mitral valve ring. That reduces the severity of functional MR, but that has not been subject to a major outcome trial to date. Next, we turn to other devices that target different aspects of pathophysiology, particularly autonomic dysfunction. The Reflex stimulation system done by CVRx stimulates with an implantable device, stimulates the carotid baroreceptors, which leads to reflex, sympathetic withdrawal and vagal activation, reduces heart rate, improves remodeling, causes vasodilatation, as well as diuresis and reduction in renal secretion. That's been assessed in a number of modest-sized trials, and we performed individual patient data meta-analysis showing a significant increase in 6-minute corridor walk test of about 50 meters, an improvement in NYHA class, a reduction in terminal pro-BNP levels, and an improvement in quality of life as assessed with the Minnesota Living with Heart Failure questionnaire score. Next, we turn to another electrical device, which is rather like an implantable pacemaker, but it doesn't pace the myocardium because the electrical stimulation is produced during the absolute refractory period. Therefore, it leads to alterations in cellular electrophysiology without an action potential. That leads to increased calcium turnover and an increase in the force of cardiac contraction, as shown here for isolated human trabeculae. That has been shown to change the gene expression within the myocardium and improvement in left ventricular contractility and left ventricular remodeling. We also performed an individual patient data meta-analysis over a number of trials shown here with approximately 400 patients, showing a significant improvement in peak VO2 that goes up to 0.93 mils per kilogram per minute, which is clinically useful increase in exercise tolerance. And that's now also being tested in heart failure with preserved ejection fraction, where perhaps the changes in calcium modulation leads more to an improvement in diastolic function rather than the potential for systolic improvement. That's presently under investigation, and an open label pilot phase was presented by Celia Lindy in the Heart Failure Association meeting just a month ago. That was a prospective multi-center pilot study of cardiac contractility modulation in symptomatic HFpEF patients, looking at KCCQ summary score as the main endpoint for efficacy as well as safety endpoints. What it showed was a very healthy increase in 18 points in the KCCQ overall summary score and 15.3 points in the clinical summary score, highly statistically significant. But a reminder, this was not a randomized controlled comparison. It was before and after study. So this requires further evaluation in a planned randomized controlled trial. Next, as we're talking into HFpEF, we have the results of a device for the management of HFpEF, and that's an atrial decompression device called Reduced Lap HF2 study design by the Corvia atrial shunt device. The primary endpoint was a composite of cardiovascular mortality or non-fatal stroke through 12 months and a rate of heart failure admissions or IV requiring treatment during through 24 months. The device here is shown. It's relatively small. That's not the price. That's the size implanted into the atrial septum with an effort to decompress the left atrium towards the right. The overall result was not significant, as shown here for the primary endpoint. However, what is shown is there was a significant interaction with pulmonary artery systolic pressure at 20 watts of exercise, showing that those patients with the highest pulmonary artery pressures actually did significantly better on the control group, whereas those with the lower 2/3 of pulmonary artery systolic pressure during exercise actually showed a strong trend to benefit. And it may be that this excessive pulmonary hypertensive response to exercise indicates a poor response, meaning that there may be other patients who get a better response. That can be assessed by looking at pulmonary arterial dynamics during exercise, as shown here, where the group has studied the pulmonary artery compliance and vascular resistance response to exercise, and that's applied to the results of the reduced LAHF2 study. We see that there are patients who have an excessive increase in pulmonary vascular resistance during exercise, and those patients seem to have a poor response. So the hypothesis was floated that patients with HFpEF or mid-range ejection fraction and latent pulmonary vascular disease, as manifest by an increase in pulmonary vascular resistance and excessive increase during exercise, may be harmed by implantation of left to right atrial shunt, whilst patients without such latent pulmonary vascular disease might benefit. And the latent pulmonary vascular disease was defined as an exercise pulmonary vascular resistance increase greater than 1.74 Wood units. Here, the results of that have shown that those patients with latent pulmonary vascular disease do worse than the win ratio, those without that do better, and that's a significant interaction, suggesting that there may well be a subset of patients who respond particularly well to this left atrial decompression device. It's important to note that resting pulmonary vascular resistance could not differentiate the response. It actually requires exercise-induced or provocated pulmonary vascular response to pick that up. So the conclusion of that analysis was that latent pulmonary vascular disease critically modifies the response to atrial shunt therapy, suggesting that in future trials, we may want to evaluate pulmonary vascular disease response to exercise before selecting patients for evaluation of such a novel device. Thank you very much. I look forward to any discussions we may have on future occasions. Thank you very much.